Good evening, ladies and gentlemen. My name is Mark Clarfield, previously head of Medical School for International Health, Ben-Gurion University, speaking to you from sunny Beersheba in Israel, 7 o'clock at night here and around the world, different hours. I'd like to welcome you to our Global Health Forum, which we hold every month or so. Normally, under normal circumstances, we have guests who come to Beersheba, who wash up in Beersheba, who we invite to Beersheba, come and give talks to our students, to our medical school. But of course, this is a different year. We didn't want to lose that function, and so we've used the miracle of Zoom to bring you people from around the world. And it really is a personal and professional pleasure to welcome Dr. Joe Sakran tonight. The most important thing I can say about Joe is he's a mensch. He's a great guy, a lovely, lovely person, a fine doctor. The second most important thing I can tell you about him is he's an alumnus of MSIH. He was a student here, one of our best, went on, as you'll hear shortly, to do all kinds of wonderful things. You can see on his screen what he's done. He has a bunch of titles. I'm not going to read them to you. He's a general surgeon. He's an emergency general surgeon, and he's had some fantastic experiences that he's going to share, some of which he's going to share tonight. He's going to speak to us about health equity, carving out a better tomorrow. I will interrupt at around 40 minutes to remind Joe we want to have time for questions and answers. Please put them in the chat box and I'll do my best to collate them. So without further ado, Dr. Sakran, the floor is yours, and thank you so much for zooming into us today. Joe.
Well, thank you so much, Professor. It is really just a great honor to be with all of you, not just as someone who has really just a special place in his heart for Israel, for MSIH, and honestly for all the incredible relationships that I have built since my time there as a medical student. So it's a real honor and privilege, and I really look forward to a robust discussion and dialogue. I can't promise I have all the answers, but I'm excited to also learn from the experience and breadth of individuals on this Zoom call. So let's get into it. You know, I can't really begin talking about health equity without really telling you my own story. And I'll just tell you that this is going to be a little bit of a different type of talk than you may expect. And so it's one of those things where I'm hoping that by the end of the talk, you'll realize that each and every one of you, regardless of what you're passionate about, have a story to tell. And being able to tell that story is so critical to being able to move the needle forward on so many of the things that each and every one of us are passionate about. My story actually all began right outside of Washington, D.C. in a place called Fairfax, Virginia. Some of you may be familiar with it. I was born at Fairfax Hospital and born to the son of immigrants that came to the States over 50 years ago. I think in search of the better life that is so typical of the immigrant story. And at the age of 17, my life really changed after I went from being a healthy high school senior to collateral damage and nearly being killed when I was shot in the throat with a .38 caliber bullet. And so it's really hard for me to start talking to you really about anything, but especially about these issues without recognizing the two surgeons, Dr. Bob Ahmed on the left and Dr. D. Mukherjee on the right, who along with their teams gave me this second chance, this really just incredible opportunity to try to make a difference in the lives of other people. And as I've told Dr. Quatel and Clarkfield and so many others before, I think most 17-year-olds, they have no idea what they want to do for the rest of their lives. And I love this Brad Paisley song because it says at 17, it's hard to see past Friday night. And I think what, this means to me, at least at that age, most of us, we have no idea what we want to do for the rest of our lives. And I think I very much fit into that, category. We don't necessarily appreciate the people that we have in our life. And so when this incident happened, it really was a huge wake-up call. And I remember actually sitting. I was actually sitting in in my room. I had been out of the hospital for about a couple weeks. I had a tracheostomy tube. I had these beet red scars up and down my neck. And I walked to the restroom, and I'm looking in the mirror. And what I didn't realize is that my father was standing in the corner. And I think, Dad looked in, and he saw this kind of look of devastation in my eyes. And he came in, and he did something that really kind of changed the entire trajectory of my life in many ways. He said, you have two choices. The first is you can, decide to feel sorry for yourself. And the second is you can take this horrible incident and turn it into something positive. And that's really, what inspired me to go into medicine. It's what inspired me to, then become a trauma surgeon. And it's what then recently has pushed me to work at the intersection of medicine, public health, and public policy. And I'll tell you, I show you this picture here because I would not be here without all these people in my life who have been there through, the good times and the bad, regardless of what's going on. And all of us have these individuals in our life that help prop us up, especially at times when we need it the most. And it's really what ended up taking me to MSIH. And I'm just so never expected to go to MSIH. I think, like I told you, my parents had immigrated to the States, and they were actually living in Israel before they came to the US, and had spoken so highly about both the medical education and just the experience and the culture that Israel brings, not just to its surrounding communities, but to the world, really. And so I had, the opportunity to spend an incredible number of years, really, as many of you know, in addition to the basic kind of US science curriculum, exploring things that really focus on vulnerable populations, whether it's disaster preparedness or refugee healthcare. And that was really just so powerful, and it really prompted everything else that happened in my life. I ended up going back to Fairfax, where I was a surgical resident under the individuals that actually operate on me. And that was really honestly something that is hard to even articulate in words, what it means to operate with the people that saved your life, and feeling that you had to be, the best version of yourself possible. It also then, led me to the trauma center at Penn, where I really refined my skills as it relates to traumatology and surgical critical care. And I think one of the things, as I was at MSIH, thinking about how do I, really incorporate the theoretical and practical skills of public health, had gotten me to take a year off and spend a year at Hopkins doing an MPH. And this really had a lot to do, honestly, with Rivka Karmi, Chaim Nagan, who, I think put so many of those important principles around public health into my mind, making me realize that there is a lot of work to be done beyond simply the operating room or beyond the trauma center. And I love this motto at Hopkins where it says protecting health, saving lives millions at a time. And I think this really kind of demonstrates both the opportunity and the responsibility that we have to really think beyond just the individual patients that we take care of. As time goes on, I think we, at least for me, the more I learned, the more I realized how much I didn't know. And when I was in my first faculty position at MUSC, I started really kind of thinking about the policy implications around healthcare and how all of this really has to come together. And so I ended up spending a year at the Kennedy School, which was a tremendous year, really understanding the integration of public policy as it relates to healthcare. And most recently, I was able to take that theoretical experience and apply it in a very unique opportunity at the federal level, working as a health policy, one of the Robert Wood Johnson Health Policy Fellows in the office of U.S. Senator Maggie Hassan. And this, as all of you know, this past year, I ended up being more useful, frankly, than I thought I was going to be because of COVID and the public health kind of implications of, the worst pandemic in modern history. So I just give that as kind of like an outline of where I've been and where I'm currently at. I'm back at Hopkins now as one of the trauma surgeons, and excited to be back here, and just recognize that I wouldn't be here without the incredible mentors that I've had in my life. I don't have any obvious pertinent disclosures to this talk. So we'll quickly kind of outline the scope of the problem. I'm going to talk initially a little bit about gun violence because this is the area I work a lot in, but we're also going to highlight the health inequity issue as it relates to so many other disease processes. We can't cover everything, right? And I think it's important to note that literally you could spend, an entire semester studying all of the health inequity problems that exist and still not get through everything. So this is a snapshot to kind of give folks a little bit of a picture, and we'll talk about some of the challenges moving forward. And we're going to end again in a little bit of a different way in me talking to all of you about like the importance of telling your story and public narrative and being able to take that narrative and turn it into action. I want to start with this picture because I think this is important. You'll see at the top, it says perception. And I show this for a couple of reasons. The first is this was a picture that was taken when I was in college. I was a firefighter at the city of Fairfax. And some of you that are looking at this picture are probably thinking, okay, there's Joe, another photo op as the building behind him burns down. And the reality of that picture is this was a training exercise. And so as we had come out of the building, the other team had gone back in. And I show this because I think it's important to understand that perception is not always reality. And as we talk about really emotionally charged issues, whether it's gun violence or racism, I think it's important to really listen with the intent to understand versus, the intent to like just simply judge people. And I think some of you have probably experienced this where you walk into a meeting and you hear someone that says something that you may not agree with. And so if you think about what happens when that scenario takes place, it's actually quite interesting because, you stop listening to them, and we know that 90% of communication is nonverbal. So they stop listening to you, and the breakdown in communication doesn't just happen for that one instance, because in the future, you remember that this is the person that said something you don't necessarily agree with. And so I think, I really try to do, again, I'm not perfect, but try to do the best job possible of trying to hear other people's point of views and understand where they're coming from. And I think that this is important. I mean, obviously I'm in the States, but I think in general, whether you're in the States or you're in Israel or elsewhere, a lot of us as humans, we have a lot of the same end goals and ideas. I think the difference lies in sometimes the ideological kind of drive of how we get there. And so that commonality that exists among us, I think is so important. For firearms, you can see that this is a public health problem that we face in the US. And you can see there that 2/3 are actually suicides, which most people don't even discuss. 1/3 homicides, and the other unintentional, and a potpourri of other things. And I think what's interesting is when you look at this, it is so critical. And again, this is not going to be a talk just on firearm injury, but I just want to show you one aspect of it. It's so critical that you look at this by age, gender, and race. And so when you look at what happens, right, for individuals here as it relates to homicide rate, you can see all ages is about 4.5 per 100,000. Well, what happens when you look at white males? Well, you can see that number drops. Okay, well, we know trauma and gun violence is a disease of young people. So what happens when you look at young white males? Well, you can see that number goes up. In fact, goes up greater than all ages. What about now looking at Black males? you can see how that drastically goes up. You can imagine the next thing I'm going to ask is, what about young Black males? So just take a look at this for a second and look at the disparity that exists when you compare this by age, by gender, right, and by race. It is significant. And I tell you this because I think we have a conversation issue in the US where a lot of the gun violence is highlighted on these mass shootings. And I'm not trying to, say that it's not important to focus on mass shootings and to figure out how do we deal with this aspect of gun violence. But the reality is mass shootings are less than 2% of the entire public health problem. And we've seen this happen whether it's at Mother Emanuel or other areas across the country. And it's horrible, and it's part of what we have to solve. But I love to show this picture because this is one of my colleagues, Dr. Campbell from UCSF, and he had walked out after taking care of a couple individuals after the YouTube shooting. And one of the things that he was really surprised about was the fact that there were all these reporters outside. And it was, I think they had 2 patients that had been brought in at the time. And what he said to them was, where were you when 4 African-American men were brought in yesterday? And I think this highlights the point that, the media doesn't necessarily always focus on the fact that every day in cities all across America, cities like Baltimore, Philadelphia, Chicago, there are young Black men that are being killed on our streets. And those stories often go untold. So I think we have a responsibility to tell those stories. Now, the issue goes far beyond gun violence. And I love this, piece where it says, all human beings, regardless of race, we're more than 99.9% the same. It's pretty kind of fascinating. Yet that small difference has a lot of implications. And as we look at racial health disparities, right, it's significant, really, frankly, across the board. I mean, whether you're looking at death rates for heart attack and stroke, which are 29 and 40% higher, respectively, for Blacks compared to white Americans. Or if you're looking at African-American women who are less likely to be diagnosed with breast cancer than Caucasian women, but are 40% more likely to die from the disease. And the same exists for cervical cancer, right? Black women are twice as likely to die from cervical cancer than white women. And the story goes on. So we're gonna show some of these different examples so you can see how they're highlighted. And again, I just picked some primary examples, but there are many that one could show. So when you look at appendicitis, I treat a lot of appendicitis. Appendicitis is one of the most common surgical causes of abdominal pain. And in fact, when you look at this study, nearly 1 million children between 2003 and 2010 were diagnosed with appendicitis. And what this study found is that pain associated with this disease process is undertreated in pediatrics. In fact, only 57% of nearly 1 million children diagnosed with appendicitis received any analgesia at all. And only 41% received at least 1 dose of opioids. And the group with the absolute lowest levels of treatment were African American. In fact, Black children are less likely to receive any pain medication for moderate pain and less likely to receive opioids for severe pain. So when you look at this, to just summarize it, Black children had 1/5 the odds of receiving opioid analgesia than white children, even after adjustment for potential confounders, right? And so, if we allow this to happen to children, those who can't speak for themselves, then how do we fare for adults? Are we better when we as adults are vocal? And I think the answer you're going to find is shockingly no. We wrote this piece in the Scientific American a few months ago, talking about racism in healthcare and how it's not always obvious. And, one of the things that we started off by saying is that, listen, you can have, 2 different individuals that come to a doctor's office to determine whether or not they need a procedure. And you can have the same presenting signs and symptoms, but the overall demographics are similar, but you have one person that's white and one person that's black, and the procedures that are recommended are not always the same. Some of you might find that surprising, but let's look at some of the data. So this was, I think, a really fascinating study that looked at 720 physicians. And they were looking to see if there was a bias, whether implicit or explicit, that is leading to a difference in outcomes. And what they did is they looked at this at a primary care physicians national meeting with 3 different simulated scenarios. And each physician viewed a recorded interview that had presenting symptoms, associated cardiac symptoms, relief of symptoms, and duration of symptoms. And they were viewing the data. And after that happened, they had to make recommendations about the patient's care. Now, all the patients had identical insurance. You can see here, I've listed some of this stuff. They had identical occupation. They had identical vital signs, cholesterol, smoking history. None of them had diabetes. All had a father who had an MI above the age of 75. And the physicians had to describe the type of chest pain, to estimate the probability of it being clinically significant, and to ask if they wanted further testing, right? And they were asked to estimate the probability of coronary artery disease and if the patient should have a left heart cath. And when you look at the results, they're stunning, but just to kind of summarize is that women and blacks were less likely to be referred for cardiac catheterization than men and whites respectively, right? And these are, physicians that are, theoretically supposed to just provide the same type of care to individuals, but the reality is that's not necessarily true. When you look at other studies, and this was another really, I think, in my mind, a landmark study that looked at, it was conducted in 2007, and it looked at 4 different academic medical centers. You can see them there, Emory and the 3 Harvard hospitals. And the objective was to test whether physicians show implicit race bias and whether the magnitude of such bias predicts thrombolysis recommendations for Black and white patients with acute coronary syndromes. And you can see here they had about 200, almost 300 ER and medicine residents, and they use these different clinical vignettes, and they had this questionnaire that used an implicit association test. Now, this was developed by Harvard, and it's a tool that's been employed in over 200 different studies. And what they found is that all 3 IATs showed statistically significant effects with stronger associations of negative attributes to Blacks than to whites, right? So you can see this, and this was done in a very objective way. When you look at what physicians were reporting, physicians reported that they had no explicit preference for white versus Black, but when you looked at the implicit bias test, that clearly was not true. Where there was a preference in favoring whites, there were stereotypes of Blacks not being as cooperative with medical procedures. And Black physicians had actually mean scores on all 3 of the IATs near zeros, where all other groups had scores in the pro-white range. So you can see that despite the explicit bias of someone saying that they don't actually have a preference one way or the other, the implicit bias is actually there. And when you look at physicians with pro-white implicit bias that was increased, so did their likelihood of treating white patients and not treating Black patients with thrombolysis. Again, a really significant, I think, study that just illustrates the fact that the implicit bias does exist and is often not recognized. So the last kind of main study I just want to show folks is the study that looks at in-hospital cardiopulmonary resuscitation. And this was using Medicare data, looking at the incident of CPR and the rate of survival. And they looked at both patient and hospital level predictors to discharge. And when they looked at all of this, they found that survival is poorer for Black and other non-white patients, and that there was no significant change in overall survival between the study period. And adjusted odds of survival for Black patients were nearly 24% lower than those for similar white patients. So the association between race and survival hospital effects, Black patients were more likely to undergo CPR in hospital that have lower rates of post-CPR survival. And among patients surviving in hospital CPR, the proportion of patients discharged home rather than a healthcare facility decreased over time. This is not just in these prior studies that we have seen disparities and health inequity. We've also seen this, and it's been highlighted significantly throughout the COVID pandemic. When you look at hospitalization rates and characteristics of patients that are hospitalized with COVID-19, and you look at the differences among white and Black individuals across the country. And you can look at this nationally, and you can also look at this from a state perspective, where despite the best intentions, healthcare workers take the complaints by white patients more seriously than those that come from communities of color. And so, this is just, I think, a very small kind of lens into this public health problem that we are facing in America. And when you look at these issues, I think it's very, very complex. There's a lot of factors that go into this as we talk about the social determinants of health and things like housing and food security and education, or if we're talking about the ability to be able to afford your medications, or to actually have trust with your healthcare provider or your healthcare system, right? Or what about the fact that frankly there exists this rub, and we see this in Baltimore sometimes, between the surrounding community and the very wealthy healthcare system. These are all issues that relate to the structural problems that exist that have prevented us really, I think, from making headway on some of these different factors that we've discussed. And part of, I think, what we have to do, and what there is a significant focus on, is trying to break down the silos that exist within cities. Right now, you have these structural issues, you have public health department issues, you have hospital and healthcare issues, and they're siloed off. We need to break down these silos and get people working together in parallel. And that's been something that has been a big focus, I think, in cities across America as well, most recently at the national level, but we have a ways to go. As it specifically relates to gun violence and what we're seeing here, it's very similar, right? Whether you're talking about treating the patient that's coming in with a potential MI versus treating, gun violence epidemic that we're seeing in Baltimore and across the country, there's a biopsychosocial disease that often doesn't get considered. And so in order to treat these complex public health problems, we have to really, change our focus. A lot of times we're trying to change human behavior, which we know in and of itself is not cost effective. We really have to approach this in a way that allows us to develop a system that makes it less likely for people either to become ill or, in this case, injured. So framing it in that way is so critical. One of the things that's come out of COVID is, I think, a stronger magnifying glass on the the health inequity that exists. And in order to address this, the Satcher Health Leadership Institute, as well as the CDC Foundation, established a health equity task force. And this task force was a very robust task force with individuals from all across the country with all different experiences. And really, the goal was to monitor and try to address the disparate impacts that we're seeing on vulnerable populations, including communities of color. And so a data consortium was created, and there was really 4 different key components here. The first is they partnered with Google in order to establish this task force to have this multi-sector data consortium that is devoted, again, on COVID-19 impact, but I think will actually have repercussions way beyond COVID-19. But then developing a standardized evidence-based practice, trying to figure out how to be socioculturally responsive from a resource perspective and from a technical perspective, and really trying to bring together the local, regional, state, and national organizations so that they can improve this collective response, whether you're talking about simple data collection or you're talking about therapeutic interventions or things like testing. I think the third piece is really trying to analyze some of the different policies that exist among jurisdictions that can exacerbate or alleviate the COVID-19 outcome. And then, of course, a real focus on mental and behavioral health, which, my brother's a child psychiatrist, so we talk about this all the time. The lack of access is just horrendous and something that really needs to be addressed. Daniel Dawes, who's executive director of the Satcher Health Leadership Institute, a phenomenal individual who's really been a leading force for health equity. And he wrote this book called The Political Determinants of Health. If you get a chance, I highly recommend it. It really, I think, puts a lot of these things into perspective and provides some really concrete ideas about, what happens from a policy perspective is really impacting individuals at the community level. Again, there's not enough time to cover so many things, but this was an incredible document that was really covering the health inequities that exist in Israel. And I think when you look at Israel as a whole, and I've attached the PDF there, it's a really tremendous document with a lot of good information. But when you look at Israel as a whole, the life expectancy is high, actually, and infant mortality rate is low when you look at it by OECD standards. However, when you stratify it based off of different indicators, whether it's looking at non-Jews versus people living in more rural areas or the periphery or socioeconomic status, we know that those populations actually have worse health outcomes. And so, again, there's probably people on here that know way more about this than I do and appreciate your comments and thoughts. But I think the Ministry of Health really is taking this seriously about trying to figure out how do we tackle health inequalities. And I think we all realize, whether it's in Israel or the US, it's quite a complex undertaking. So I'm just going to end with a few things about really kind of telling your story. And, as a surgeon, when I talk about this, I think a lot of my colleagues, especially in the surgical world, think this is a little bit foo-foo. And they're like, oh, what are you talking about, Sakran? Like, it doesn't really necessarily always make sense to them. And I think hopefully you'll find why this is important. And I think one of the things that I've been really proud of over the past few years is seeing how integral clinicians have been, not just docs, but the entire clinical spectrum of individuals that care for patients as it relates to social movements. And this was a great piece out of Philadelphia by one of my colleagues, Dr. Goldberg, that said an apolitical profession wakes up, and she was referring to the trauma surgeons that spoke out about gun violence. And a lot of you probably heard about what happened in 2018 with This Is Our Lane, when the NRA came out and said that we as doctors didn't have a role in coming up with solutions as it relates to gun violence prevention. All of us that care for these patients obviously know that we're the ones that are there taking care of them day in and day out. And I think, and I think many others do as well, that we're really a central part of this conversation. And those those things that happen, they may sound like small kind of things in the grand scheme of what we're doing in healthcare, but they lead to a lot of incredible collaborations and things that you may never expect. And this specifically led to the largest medical summit, I think, across really any public health problem, where there were 44 organizations that were brought together, all the leading professional organizations, to discuss how do we approach issue from a public health perspective. And you can see there, some of the public health interventions that we came up with, whether it's, safe storage or, dealing with the social determinants of health, like we were just talking about, or policy. One of my professors from the Kennedy School, Marshall Gans, who's the world expert in public narrative, he talks about this in terms of the story of self, the story of us, and the story of now. And it's actually really fascinating because, I think most of us as clinicians, as scientists, as researchers, we're so focused on the data. And I don't want to minimize the fact that, of course, the data is important. But the reality is the data does not change the hearts and minds of people. And that's important if you want to actually see change. And he talks about this in terms of going from value to action, whatever that value may be. For me, it's, ending gun violence, right? That's my why. For each of you, it's going to be different. But in order to do that, it's done through emotion. It's done through being able to tell those stories. And the story doesn't have to be as dramatic as being shot in the throat, right? Each and every one of you have a story, and figuring out how to package that up and how to deliver it is critical. In fact, I always ask my medical students, I'm like, what's your story? And at the beginning of the rotation, they're like, I'm a third-year medical student on your rotation, and I want to do this, right? By the end of our rotation, their answer is very different. And so just something for all of us to think about. If you haven't seen this Simon Sinek talk, this focuses a little bit more on the why that we're talking about, the purpose. And it's like 10, 12-minute talk. But the point here is that when you look at really successful companies, like Apple, for example, the reason they're successful is not because they tell you what they're going to do. They're successful is because they get you to believe in what they believe in, right? And that's the why, and that's what we need to capture in some of these things that we're doing. This is one of my favorite pieces out of Harvard Business Review, where they've looked at leadership, and they followed 10,000 West Point cadets. And what they did was they looked at internal versus external motivations. So like internal motivations being things like the duty to serve, and external being things like, okay, there's school loans, we're going to get paid off. You may not be surprised that those that were internally driven were actually more successful along their career. Again, success is all determined by each and every one of us, but just something to consider. Since Parkland, there's been 1,200 American kids that have been shot and killed, over 1,200. And I just think that's absolutely unacceptable. And I've just been so proud of the young people in the States that I think have really re-energized the conversation, whether you're talking about gun violence or racism as a public health problem. They've really done, I think, a tremendous job. I never really kind of appreciated the power of my own story, to be honest. And it wasn't until I was in Philadelphia, where I was a fellow there, and what we would do is we would bring in kids from surrounding areas. And I'd give them a tour of the trauma center, and then I would talk to them about gun violence. And the first time I did this, I didn't tell them my story just yet, and I was just giving them an introduction to the public health problem. And they were kind of paying attention, but not really. Now, look, they're 14, 15-year-olds, so like we all get it, right? I went ahead and then told them my story, and all of a sudden, all of their eyeballs focused on me. And it was frankly a reaction that I had never seen before, and one that I wasn't expecting. And I think in that moment, what I realized is I went from being this person wearing this white coat to someone that could actually relate to what these kids were facing in their communities day in and day out. And I think that's so important as we try to address some of these issues, right, within communities across America or in Israel or elsewhere. So I'm going to leave you with a couple things. You know, Professor Gann says if you're in public life, you have to learn how to tell your story. I would actually switch this around. I think regardless of what you're doing, you have to learn how to tell your story. I think it's so important in the impact that you can make on others. And when you look at these kids, they don't need a caption because they've done such a great job of telling you their story. So my thing to you is, what's your story? And really try to think about this. The other thing I just want to say and just end with is that, look, like, I love what I do as a clinician. And I found this in a fortune cookie, and it said, to love what you do and feel that it matters, how could anything be more fun? And I think it's true. I mean, the fact that someone is going to put their trust in your hands and allow you to take them to the operating room, I just can't think of anything that is just more gratifying. But one of the worst things and worst parts of my job is having to talk to these mothers and fathers and sisters and brothers, frankly, and tell them that their child that left that morning is never coming home again. And I'll never forget, I think I know definitely Lynn, I've told her about this, but I'll never forget a recent story of a 17-year-old kid who was shot in the head, had a devastating traumatic brain injury. And I had to go up to the ICU and talk to this kid's mom and, tell her essentially that, her child was never coming home again. And as I went up to the ICU, I was, in the nursing station, and I was looking in, and we had these big, like, clear glass windows. And I'm looking in, and I just, see this mom holding her son's hand and realizing that what I'm about to do is completely rock her world. And it's the hardest part of my job. And it never gets any easier. And so I walk into this room and, introduce myself and the team to the mom. And I begin telling this mom about her son and the devastating injury. And as I began telling her all of these things, she began telling me about her son, how he was the first in their family to graduate from high school, which in Baltimore, in the African-American community, is a big deal. He had hopes and dreams, just like so many of us, to go to college. And none of those will ever come true. And as, she was telling me that, she looks up, and I think she saw how emotionally impacted we as the healthcare team were as well. And she walked over and she did something that I'll just never forget, but she put her hand on my shoulder and she said, "Are you okay?" Now just imagine this for a second. Here's a mom that just lost her son, and she's asking us if we're okay. I think it's moments like that which really kind of restore my faith in humanity, and that get me to wake up every morning to try to make a difference in people's lives. And in my case, reduce firearm injury and death in America. I'm here chatting with you because I have incredible partners that are doing the hard work, which is keeping the patient at the center of the equation. And I'm just so grateful for so many mentors and for all of you for really providing me the opportunity to be here. Thank you very much.
Oh, that was brilliant. Can you hear me? You can hear me?
Yes, sir.
Not unexpectedly, that was absolutely brilliant and inspiring. And I want to thank you on behalf of all of us for that. Really, it's late. It's already late in the evening here, and I've been working since early in the morning. But it was really worth the wait. Boy, it was really worth the wait. So thanks again.
Thank you for the opportunity.
Our pleasure. So there are more than 100 people watching and listening to you tonight, and I got a whole bunch of questions. but I'm not going to be able to ask you all the questions, but I'm going to try and do a quick survey through them. First, before I do that, I just want to thank our team in New York for organizing this. Had it been left up to me, it wouldn't have been technically nearly the same. So thanks to our AEBGU and New York team. Tell me something. Just let's start with our medical students. One of your early slides, you said it's hard to see past Friday night. That's a nice slide. Probably a good song too. Tell our students briefly, they've got this COVID-19 year. Half of them are not even here. Most of the first and second years are learning from abroad. What kind of advice can you give them to sort of see through the year to survive until the vaccine hopefully rescues us? What advice can you give them?
Yeah, so look, the one thing, let me just start out by just saying the fact that this is hard, of course, on so many different individuals, but I think especially our students, whether it's the MSIH students or the students here at Hopkins, this has been like completely disrupted the entire educational curriculum and experience that just across the world. And I think it's been something that frankly, we have never had to face in modern day history. So I just want to first recognize that it's really difficult, and for anyone to dismiss that, they just are either not in touch with the reality or haven't been paying attention. One of the things that I would just say is that everyone is going through these tough challenges and this adversity. And in my kind of experience, adversity always makes you stronger. Whether it's having to go, do your educational curriculum, through Zooms and different non-traditional ways, whether it's, being injured and being a patient, all of these experiences are going to make each and every one of you stronger. And I think at the end of the day, when we look back at this in 2, 3, 5 years, we're going to remember these times and remember how all these different experiences led us to who we are as individuals. In fact, they might even drive some individuals to have more of a public health focus or maybe more of an infectious disease focus. So I would just say that I recognize the difficulty, but I would also say that try to make the best out of the situation that you have. I think so many educators are really, struggling to do everything they can to try to make this experience for students the best possible experience under these circumstances. And so, and the last thing I'll say about this is also I never liked the term social distancing because I think it should have been called physical distancing.
Correct. Agree.
The human to human interaction and that lack of interaction, I think, is taking a big toll on individuals and society in general, but especially on healthcare workers, especially on our medical students that are now rotating through and having to see, these type of issues and not really have an outlet to debrief or to discuss it. So I would just say that, try to find your safe social networks that you can still maintain some of those conversations because they're so critical.
Great, thank you. Well, that brings me to the next question. One of our medical students, and I want to ask you the same thing, and this is a difficult question to answer, I know, but I'd like to hear your thoughts. How do you balance your clinical work, your personal work, your family work, your public health work? I know the answer is you don't, but how do you do the best you can?
Yeah, I feel like a little bit of a hypocrite answering this question because, in just full disclosure, I have the worst probably balance ever. And it's been something, I think it's been one of my biggest weaknesses, to be honest, is, after my incident, I was so professionally driven that I forgot about my personal life. And here's what, I don't know if this will be helpful, but here's what I've come up with recently. Because recently over the past, year or so, I've been trying to make it more of a specific focus. And I think it's important to try to do that and make time for things that you think are priority, whether that's family, whether that's working out, whether that's spending time with friends, whatever it is, you have to make that a priority. Similar to to, brushing your teeth or the basic activities of daily living, right? And so that's what I've tried to do, and actually like physically like schedule time for those things. And I will tell you just a couple things, which is number one, having a balanced personal life, I actually think makes you more successful professionally. And you don't always realize that. Number two is it's very easy to put this on the side. And next thing you know, you wake up 5 years later and you're kind of in the same position. You may not be married or have a significant other, or maybe you don't have kids, or maybe you're not spending enough time with the family. Time is precious. Time is the most precious commodity. And what I've just essentially told myself is I don't want to have any regrets. I don't want to take my last breath and say, oh man, if only I had done, this and this and this. So yes, it's great to be ambitious. It's great to do all these things, but it's also great to try to be deliberate about, the things that you're doing in your own personal life. And I think as you continue to grow professionally and you become more focused in what you want to do, some of the things that are not really directed towards achieving your goals will fall by the wayside, and it allows you to have some more of that balance. So again, I feel like I'm calling the kettle black, but that's, I think, the best answer.
I think that's a nice, honest answer. This is not an easy thing to do, and none of us who get anything done in the world do it by spending less time doing it. The question of balance, and I think your advice and your vision that in order to do what you want to do, you have to look after yourself too, is probably great for us type A type personalities. Most successful medical practitioners have some of that in them, but thank you. Returning to one of the subjects, some of the subjects you spoke about, we got an interesting question about the inherent bias, the studies of inherent bias. The question was, do you know whether this inherent bias that is picked up by these studies gets better or worse with time? Meaning that if it gets worse with time, is it possible that it's something learned by our profession? Or if it doesn't get worse with time, is it something perhaps we bring our biases into our practice? Any thoughts on that?
Well, I think when you start looking at the field in general of looking at like disparities and these issues is relatively young compared to just medicine in general, right? That's the first thing to say about this. The second thing to say, I think certain aspects have gotten better in time in the sense that we're now actually starting to have those conversations and the realization that these disparities actually exist. And it's becoming a focus within healthcare systems, departments, schools of medicine, where this was never the case before. Now, part of it is like, of course, building that infrastructure to be able to like intervene and to recognize it. And we're doing it here at Hopkins, where there's a big effort to look at this bias, but we still have a long ways to go. And I think part of it, and we saw this, Mark, in COVID, part of it stems from the fact that we still don't have really robust data necessarily that aligns at the local, state, and national level. And that's part of what this collaboration that the CDC Foundation and the Satcher Health Leadership Institute are trying to do, because the data is going to be critical, not just to allow us to figure out where specifically the pockets of problems are, but also whether the interventions are actually useful and are making a difference. So having those metrics are critical.
Yeah, thank you. One of the questions related to gun control asked whether this is, you're framing it as a public health issue, where many people have dealt with it as primarily a political issue. And you've just been through a very bruising political campaign that isn't really over. It will be over soon, but it's not quite over yet. I don't want to go into it in any more detail than that, but how do you see this as a political, because the question was, the only way to solve this is a political solution. And why do you bring a public health approach to it? That's the question. Thoughts on that?
Yeah,
political versus public health.
Yeah, no, thank you for that question. Look, a couple things to say about this. When you look at public health problems and you try to define what they are, public health problems are complex health issues that occur in different geographic regions across the area, in this case, America, right?
Right.
So by definition, it's a public health problem. That's number one. Number two is there needs to be policy that is in place to really allow people to understand and to be able to address this issue. I totally agree with that. And part of that is political. But I think part of it has been political is because we haven't had a health focus on it. When you look at in the 60s and 70s, right, there were motor vehicle fatalities. And what did we do then? Did we get rid of cars? No. We just came up with, seatbelts and airbags, and we made roads safer. We switched from really trying to figure out how do we change that human behavior that we were discussing and developing a system that makes it less likely for people to be injured. And that's why the fatality rate dropped. And so in looking at this as a disease, I'm looking at all the different ways, and there's no one solution, but all of the different ways that we can implement a multifaceted approach. Some of that, right, is going to require policy. I totally agree. And some of that policy is, going to require, I think, unification and really building on the consensus that I frankly think exists in America, but we don't always see through the media or through the eyes of our politician. The one thing that I think we all sometimes forget is that at least in America, most governing happens at the local and the state level. And in fact, in 2018, there were over 67 pieces of legislation around gun violence prevention that were passed. A lot of people don't recognize that.
Different states, you mean different jurisdictions?
Different states all across, states all across America. Why did that happen? Part of the reason that happened is because you have, the moms, showing up to the state house. You have the doctors talking about what they're seeing on the front lines. You have researchers talking about the evidence of how to lock up your firearms. So the 4.6 million children that currently live in homes with unlocked and loaded weapons are not at risk, right? All of these different things. So the public health approach has been driving those policies and what the policymakers do. Do we want to see change at the federal level? Yes. Is it going to be very difficult with, the way it looks like the Senate is going to be controlled and the lack of unity and the emotionally charged nature of this issue? Absolutely. But I think, have to continue pushing it and trying it. And I'm confident, the last thing I'll say about this, and again, I don't want to get into the politics, but I'm confident that a President-elect Biden and Vice President-elect Harris is going to have this as one of their priority issues as we finish, dealing with the COVID pandemic. It's a very complex issue.
Thank you. I guess all I can say to that is amen. Joe, we could go on. I could talk to you for another hour or two, and so too could the audience. We still have the same number of people on as at the beginning, which is a good sign. I think the COVID-19 is a terrible pandemic, but there are a few small benefits or large benefits. One of it is the ability for all of us to see you tonight without you having to fly here. So on behalf of all of us, AABGU, MSIH, BGU, everybody, and myself personally, my guess is you would have been the same star you are, whatever medical school you went to, but I'm really proud you went to our medical school. And I hope that you'll come back and see us in person. We love to see you on screen, but we'd love to see you even more in person. So,
well, Mark, that means a lot coming from you, and I'm just so grateful for AABGU and for you and Lynn and so many of the individuals that at MSIH and both in the New York office and Beersheba that made this happen. And I don't know who's still on the call or not, but just to the MSIH students and maybe alum that are on there, I think you're in a really special program that currently you may not realize how it's going to impact your career. But, I would say, keep working hard and hold the faith. And if I can ever be of any help, folks know how to get in touch with me. But I'm just really grateful to be with all of you tonight. Thanks for giving me the honor of this hour, and look forward to touching base in the future.
We really appreciate your time. So on behalf of MSIH, BGU, AABGU, I want to thank you, Joe, Dr. Sakran, and I want to say good night to all of you because we promised we'd finish on time. So all the best. Stay safe, stay healthy.
Bye.
Thank you.